Imagine if vaccines could be created at previously unimaginable speeds. That is becoming a reality thanks to new platform technologies that can rapidly create multiple vaccines designed to protect against deadly diseases, including COVID-19.
So we've been looking for technology that could make a vaccine from discovery to being in a vaccine vial within a matter of weeks.
When scientists detect a potentially deadly new pathogen, they can now map its genetic blueprints and synthesize small sections of it. These tiny, harmless pieces of artificial genetic code are being used to create a safe, effective synthetic vaccine against the coronavirus that causes COVID-19.
The manufacturing of the vaccine is going ahead. So we anticipate we'll be starting our clinical trial, our first clinical trial, in June of this year.
That will show if the vaccine successfully protects against COVID-19.
We already know that the manufacturing partners we're working with can produce 5 million doses within a period of weeks. Going from millions to billions of doses then becomes a global effort.
The new vaccine technology platform called RapidVac makes that much easier than before. Because each new vaccine is based on a genetic template, it can quickly be shared with vaccine manufacturers located around the world. That will allow enough vaccine doses to be equitably produced for the global population and much more quickly stop the spread of a pandemic disease. This will be particularly important for poorer countries that lack robust healthcare systems and have large populations living in dense urban cities and slums, where social distancing is impossible.
I think science is absolutely critical to getting out of this pandemic.
In the future, vaccine platform technologies such as RapidVac will be needed to rapidly and cheaply produce vaccines that can protect against other emerging diseases.
COVID-19 needs to drive the discussion so that we don't get caught out the next time.
Innovations like this will help us save more lives. Let's get behind the future of vaccines.
So I'm pleased to welcome to the stage the second Grand Challenge team, Your Health in Your Hands, Future Personalised Medical Technologies for a Sustainable and Effective Healthcare. Presenting this evening on behalf of the Executive Leadership Team are Anne Bristol from John Curtin School of Medical Research, Matthew Cook from the ANU Medical School, Jane Despera from the Research School of Population Health, and Anthony Tricoli from the Research School of Engineering.
Good evening. My name is Anthony Tricoli. I'm an engineer and leader of the Nanotechnology Research Laboratory at ANU. I'm very happy to be with you tonight to speak about a topic that brings us all together, independently of where we are from, which language we speak, or cultural heritage. This is our health. In the last century, the incredible amount of innovation, progress made in medicine and biomedical technology has led to the rise of modern medicine. This has dramatically increased our quality of life, and if we look at one of the most common indicators for this, the life expectancy at birth, this has increased from about 40 at the beginning of last century to more than 80 in many countries now. However, not all is gold. Actually, today, more than ever, we face extreme challenge if we want to ensure that in the future, healthcare remains sustainable and equal for everyone. In particular, if we look at the distribution of life expectancy in the world, in this map, we will see that health outcomes are not uniformly distributed. The Asian Pacific, for example, with its beautiful diversity of culture, geographical location, and politics, experience among the biggest variation in life expectancy, going from 40 to more than 80 years. This is not a problem which is only for developing countries. Also in developed countries, if we look at the cost of healthcare as a percentage of the gross domestic product, this has been increased dramatically. In Australia, healthcare expenses have doubled in the last 50 years, going from a nominal value of 10 billion to more than 150 billion in the last 35 years. This is not sustainable. And many countries are considering cuts to the healthcare system, which are actually a risk to decrease healthcare outcome for the most vulnerable part of our population. In Australia, despite having one of the best healthcare systems in the world, in fact we are very green there, not all is green. Actually, Australia is a microcosmos that represents some of the problematic that we face in the Asian Pacific, remote area, vulnerable community. If we look into remote area, in Australia, the burden of disease is almost twice as high as in urban communities. If we look at diabetes, Indigenous Australians experience twice as high incidence rate and 3 times as high worse health outcomes. There are many issues that relate to this topic. Two of the main that we will address in our grand challenge are one shown in this picture, which refers to the accessibility of healthcare. On the left side, you can see the first magnetic resonance imaging, MRI. It was kind of a scary instrument where you had to wear actually a magnetic jacket to get through images, right? And now, about 40 years later, it's actually the anniversary now, we have some fantastic instrumentation which has gone far behind our imagination of what we could do and help us in diagnostics of many important medical issues. However, something has not changed. The instrument is still quite big, it's still in a building, it's very hard to access, especially if you're in a remote location. So transforming this paradigm that we have to be in a big building to get medical health care is a big, important issue if we want to change the accessibility to health care. The other issue that we're looking at is that we are facing, it's not easy, despite we had tremendous progress in the development of precision drugs. Precision drugs are drugs which are fantastic at addressing one mechanism of disease, so they're very effective. We don't know who benefit the most. If you look at the top 10 crossing drug in the United States, Copaxone is one of them, and is utilized for multiple sclerosis. You will have to give it to 60 people, so all the red and one blue, for one person, the blue one, to be positively affected. This brings a tremendous cost and also side consequence for the people that actually are not beneficially affected. The reason of this is that disease is complex. Disease is a combination of our DNA, genotype, how this genotype develops in the course of our life, is the green part, and environmental exposure. For example, how much sunlight you've been exposed to, what have you been eating, and some other things. So in the future, if you want to be able to provide precision medicine effectively for everyone, we have to go from that picture to that picture, where we can use genetic information, environmental exposure information, so how you're doing your metabolism, to target the right person with the right medicine. So this is about our grand challenge. Our grand challenge is to ensure that in the future, we will have a sustainable, equal, and high-quality healthcare for everyone. We plan to do so by deep personalization of healthcare. And with this, we mean developing new, portable, deployable technology that non-invasively, by measuring biomarkers that can be measured without blood analysis, can tell us how we're doing independently of where we are located. We plan to integrate this with the emerging genomic approach. There will be a key to understand the diversity of response that our body has. And we plan to use all this data to artificial intelligence process to understand diseases better, to understand why they come and how to treat it, and provide better health outcomes for everyone. Now, this is not a technological process alone. If we want really to have a transformational healthcare, we have to come out of our labs, of our computers, and start working with people. So we will also develop a social, ethical framework to see how this digital transformation of healthcare, which maybe in some sense is imminent, will be deployed in the world.
Thanks, Antonio. Good evening, Matthew Cook's my name. I'm a Professor of Medicine and my interests are in immunology and genomics. Also in clinical practice, I've just come from my clinic, in fact, where there were patients who were attending for their 3 or 6 or 12 monthly checkups. And some of them, when I inquired how they'd been going, they said, well, I'm fine. But if I had been here a month ago, it would have been a different story. But they weren't there a month ago, they were here today, and this is one of the challenges that we face in medical practice at the moment. It's episodic. Clinical consultations are episodic, and often the investigations that we perform to go along with those consultations are also episodic. And those investigations often involve something like this, where a blood test is taken to see how a patient is getting on. So our first challenge is to disrupt this process by devising new mechanisms for monitoring patients continuously. Not through invasive mechanisms like this, but through non-invasive processes where we can assess how things are going by measuring analytes which are present in sweat or tears, and therefore it will be feasible for individuals to wear these devices. This will also mean that it's possible to monitor patients irrespective of their location. It doesn't matter whether they're in Canberra or Central Australia or indeed elsewhere. Now, the second challenge that we face at the moment is insufficient understanding of the mechanism of disease. And Antonio has also already alluded to this, that a major objective in current medicine is to be able to personalise treatments. Now, we know that this is crucial because if we take any complex disease that you can think of, not every patient with that diagnosis responds to any particular treatment. So we already know that diseases are heterogeneous. And dissecting this heterogeneity becomes even more important when we have access to drugs that work in a precise manner. Now, precise drugs work usually because they target a single molecule in the body. And so to understand which patient should be matched to which particular precision therapy, we need to understand the mechanism of disease better. It's no longer sufficient to make a diagnosis based on phenomenological criteria, which was the sort of 20th century approach. Now, at the moment, the best pathway we have to resolving this disease heterogeneity is genetics, by elucidating the genetic variation that distinguishes patients within a particular disease category. Now, for most of the history of genetics, at least in clinical genetics, this has been approached by looking at single genes. But now we have the capacity to look at all of the genes in a person's makeup, the so-called genome, and we can characterise variation across the entire genome. So our third challenge is to consider this avalanche of data. If we're going to be monitoring individuals continuously, monitoring variables with increasing sophistication, and then combining that with genome sequences. The genome is large, it's 3 billion bases, and each of us differ from each other by about 1 million of those bases. So right there, characterising the extent of variation is a substantial task. But then if we need to integrate that with phenotypic variation, then the computational challenge will be substantial. So our third challenge is one of computation and machine learning to take advantage of these large data sets. Now, each of those are significant challenges in their own right, but what we think makes this a grand challenge is the combination of these approaches to resolve these questions. And we consider this to be the basis of a virtuous circle of discovery, where information which is coming in from the biosensors can be interpreted in the light of conventional aspects of patient evaluation. But then we will have additional information based on complete cataloguing of the variants across the entire genome in the patients within the cohort. And if we're able to characterise some of these variants that are likely to be important in the causal pathways of disease, then we'll be making real headway towards understanding mechanism of disease. And that information will then be able to further inform how we actually monitor disease. This is all too much for a human brain, mine, and so we need to take advantage of the capacity for machine learning to integrate this information. Now this becomes a virtuous circle because discoveries here may influence future choices for analytes to be studied through the biosensors. And then of course we'll be able to evaluate whether that assessment has been correct through further clinical studies. And there will be a constant process of refinement through iteration of this circle.
I won't use that. Can you hear me okay if I don't use that? Hi, my name's Jane Desborough. I'm a registered nurse and midwife, and I'm also an early career health services researcher. The questions I always ask are, where are the patients? Where are the people? What does this mean for them and for their health? Did I hear someone ask, what is clinical genomics? What a great question. Clinical genomics is the use of genome sequencing to inform patient diagnosis and care. We will combine this information with the development of miniaturised, non-invasive wearable devices, things like a Fitbit, a bracelet, a patch on your skin, even a specially designed toothbrush. The dynamic health data generated by you, the patient, or your family member, will radically change our understanding of diseases. As well as improving our ability to diagnose and monitor your health, it will lead to new models of patient-driven decision-making. Our vision builds on the ANU's culture of academic excellence, bringing together a group of world-leading researchers from across the university. Researchers who are passionate about making technology work for all of us, improving the health of all people, regardless of gender, age, where you live, your social circumstances, listening to what you, patients, carers, your families, have to say about your experiences, and incorporating these needs and desires into the technology as we develop it, and then implementing this technology into the health services that we use every day in a way that is ethical and effective. This grand challenge will act as an incubator for innovation in biomedical research within Australia, the Asia Pacific and further afield. Our implementation frameworks will place ANU in a unique position to advise and lead policymakers on the imminent digitalisation and personalisation of healthcare. We will use value-sensitive design to embed particular values into the technologies, the most obvious being patient and clinician perspectives and the technical aspects of cybersecurity. This recognises the range of values, ethical and individual, involved, and that decisions have to be made between these. For example, patient privacy versus informational security, or patient usability versus privacy and security. What's exciting is that this is not just business as usual. It's transformative because it's data. The data for decision making is being made available to patients as well as clinicians and researchers. It's a game changer in that it'll foster patients' expertise about their own health, leading to better collaboration, better decision making, better management of symptoms and early recognition of disease progression. As you can see, we have a number of partners for our project, patient representatives, including MS Australia and Diabetes Australia, government, research institutes and key industry partners. We have good working relationships with many of them and we're eager to collaborate with new partners as they come on board. Our strong local networks will enable us to demonstrate this project locally in the first instance, and then we will extend this work with our national and international partners. I'll hand over to Anne.
I'm Anne Brüssler, an early career researcher with a passion for multiple sclerosis. And in the next few minutes, it is my task to get it a little bit more into the projects. So basically, our grand challenge, we build on 2 research pillars. The first one is about early disease detection and management. So we chose diabetes as our model disease in this case. If you look at that map, you see that we have diabetes is a pandemic disease and affects people all over the world. But if you look at the Western Pacific, we have an extremely high incidence of that disease. When you look at the numbers, this is not going to stop. The disease is going to be more and more prevalent in the future. So bring that down to Australia. At the moment, we have about 1.7 million Australians affected by diabetes. And it's not hard to imagine that this puts a very high burden on our health system. So where are the challenges here? So first of all, diabetes is often underdiagnosed. So 1 out of 4 patients actually gets diagnosed very late and has already consequences of the disease. Think about problems with sight, kidneys, even stroke. Another problem already mentioned is that we have about a double as high burden in our indigenous population. And if you think about remote versus city, you have a 2 times higher risk of dying of diabetes if you're not in direct access to hospitals. So our challenge here is to make early diagnosis and disease monitoring independent of where you actually live. So we defined projects around this problem. One is about kids with diabetes and kids at risk. So here we can combine our genetic approaches with non-invasive wearables, testing, for example, retinal function and breath, to monitor the disease better. Then we are looking at gestational diabetes. This is in particular interesting because it's a very defined thing, only affecting pregnant women. And it also has a huge impact, not only on the mothers, but also on the future risk for diabetes of the baby. So the big challenge here and the overall aim is to actually develop these devices and approaches and bring it out in the remote communities. The second pillar of our research is a more 21st century kind of problem. And as you have heard before, it's about personalizing precision medicine. Here, we chose multiple sclerosis as our model. So, as you've heard, in multiple sclerosis, it's a very complex disease and includes not only genetic predisposition, but also a lot of environmental factors. So what makes it so devastating is that A, it affects the central nervous system. So we don't know, depending on where the disease hits you, what outcome it has. It could affect your motoric skills, it could affect your eyesight, it could lead to cognition problems, pain, fatigue. So it is a very, very variable disease. And it affects mainly women between 20 and 40 years, in a very early age. So we heard that here we have actually a variety of precision therapies available. But the question is how to target the right therapy to the right person. So our project here is to include, what you've heard before, routine diagnostics with a continuous data monitoring of extra disease markers, feed that to our artificial intelligence machine learning, and that way we can actually develop devices to monitor even more sensible monitoring systems. If we include now the genomic disposition and your specific genes, then we have a way to maybe find not only that one person who reacts to the treatment, but find treatments which react to more people. And if we do that over and over again and feed back into our circle, we might be able to target most of our patients. So just imagine, you you live in a remote area, and you have kids, and you know from your genes, from your genetics, that they're at risk of developing type 1 diabetes. So you're not able to go to the doctor every week, so get them checked, you're worried. So now you could get a device, let's say a toothbrush, that actually measures in the breath or in the mouth of your child markers for the disease. So it will be fed to a cloud, it will inform the clinicians what's happening. So you can detect the disease early on and don't risk to develop bad effects early, because of this misdiagnosis or late diagnosis. Or another example, let's say you get diagnosed with multiple sclerosis. You get put on a treatment. And now you wait. If it works, you cannot do anything. You have to wait another 3 months to see your doctor. Or you have devices which actually monitor you every single day, multiple times. Or you're doing certain tests at home, so you can do something actively to inform about your disease progression. And that way, you might be able to pick up slight changes in your disease, even before it comes to a relapse. So this, just imagine, would transform our thinking of disease monitoring.
Tonight, you've seen 5 of us. Hannah is sitting there. And this is not enough, obviously, to address such a challenge. We are already 52 researchers from ANU, 27 female, 25 male. We draw strength from all 6 colleges of ANU involved in this grand challenge. And we have world-leading expertise in all the disciplines required to make this grand challenge not only a dream of a vision that we have now, but a reality. With this, I have to say, 52 people, 100, 1,000, is never enough. And we will need all the help possible. And because of this, I would like to get you all to support this grand challenge, because we believe it can lead to a change the paradigm of healthcare, leading to a better, more sustainable healthcare for everyone in the future. This was your help in your end. I would like to thank you for your attention, and we would like to try to answer to your questions in the next minutes.
Thank you very much. Again, I'd like to invite the panel to stand at the front of the room, and again, I would open the floor for questions, please. There's a mic over here, and there's one over there.
Hi, Ian Peters from Diabetes Australia. Good to see the priorities are on the right things, diabetes and of course MS. We have a lot of challenges in diabetes, and my great focus in all the things I do every day is about trying to early diagnose people, because we live it far too long. But the thing, and all of this is really exciting. I think it's absolutely brilliant. The one thing that sort of struck me as we went along is our Indigenous people who are more prone to diabetes, and the part that is always a challenge to us is the remoteness. And it may be an unfair question to ask you about the technology and how it actually goes, because clearly you're not going to be able to read it every day. I'd sort of like to understand how that's conveyed back, if that's something that you can answer, but also about the practicality of getting into remote Indigenous communities and being able to sort of organise that and make sure that things happen and what their effect would be.
Thank you. This is an excellent question. I will answer to the first part, which is the most technological aspect. So, detection of diabetes, type 1, for example. This is very important because we have seen that there are tremendous consequences if this is done too late and can lead to many side effects. And in the last years, we have been able to demonstrate that you can measure biomarkers for diabetes non-invasively throughout, not with blood analysis, but by other means. And these biomarkers can be utilized for the non-invasive diagnostic of diabetes. One of the most important is the amount of acetone, ketone, that come out from your breath, of your skin. We have developed a device which is smaller than 1 millimeter, which is able to capture a difference in acetone concentration in your breath if you are diabetes type 1 untreated or not. Now, in terms of how we can access this technology remotely, you could have one of these chips in a bracelet on your phone. This can transmit data as long as you have an network offering to a health database. And this can help with the remote diagnostics of diabetes type 1 already almost today, if you're able to push the technology a bit forward. Now, with respect to Aboriginal community, we'll let Jane.
Hi, thank you for your question. I think I need to point out to start with, often when we think of Indigenous communities, we automatically go to thinking of remote, whereas a large number of Indigenous people live in urban environments. So engaging with Indigenous people, probably in the first instance, would start on a local basis. And we acknowledge that, in fact, engaging with Indigenous people and engaging with them on this project involves starting with community, starting with country, and involving them from the very start in the co-design of what's going to work for them, what do they want, what sort of devices would they use, actually do they want to use these devices, but you know, so it's a very slow and iterative process, and part of our very strong focus on patient engagement from the beginning, and implementation would involve engaging with Aboriginal and Torres Strait Islander people in the way that works for them, and starting that in as early as possible.
Thank you. Question. Just a quick one. We've got another 3 questions, and I'm going to have to wrap up. Sorry, we're over time.
So just so how I see it is, you think of a pregnancy test. You know? So it's not substituting the clinician. It's just an initiation to go to see one.
Hi, my name is Crystal Hammond. I'm part of the community who has type 1 diabetes. So this really interests me a lot. I think it's a great idea. I was just wondering who will make these machines? How will they be, given to the communities that are, not in big cities, and how will this be funded?
That's an excellent question. So it's a bit how we bring our discoveries outside of the lab. So we already contacted and we have received a letter of interest from 4 major companies which are active in the area of biomedical device. So we plan to partner with them to develop the device. Now, in terms of, let's say, cost, funding, and deployment of this device, we plan to actually partner with different organizations, mostly political, governmental organizations, and we hope to be able to convince them that if you invest early on us, on your health, the return will be such that the healthcare costs will decrease while the quality of healthcare will increase. So we hope that we will be able to achieve this in the long term.
Thank you. My name is Vanessa Fanning, and I'm a person with MS. I think anyone who has MS would be incredibly excited by this project, because our experience is that we're sent along to have MRIs. That's a very expensive technology. We do it probably every year, sometimes more than once a year, and it's well established now. I think that it's a very blunt instrument, and it doesn't tell you much about the progression of the disease. So what you're proposing to do is fantastic and very exciting. And I think people with MS are very good at monitoring and gathering knowledge themselves and gathering evidence. There was a passing reference to microbes, and there's a lot of discovery now happening about the microbiome. I just wondered whether that's going to be looped into your project.
So it's an excellent question, and so I think it was a part of the slide that talked about the interaction between the environment and the genome to cause disease. And so even though the microbiome might be considered part of us, it also is thought to bring about disease through its interactions with us. We're setting ourselves a fairly substantial task already by looking at the influence of variation in our own genomes with various physiological markers. But we're also doing that to try and get a better understanding of what the mechanism of disease is. And so when we're looking at diseases of immunity, such as MS or type 1 diabetes, then often those mechanisms lead us back to how we interact with the microbiome. So indirectly, we circle back to that question.
Again, I appreciate there's a lot of interest and other questions that I'd ask you to reserve those, and I'm sure, again, you have the names of the members of the team now. I'd be delighted to engage with you after the session, but please join with me in thanking Team 2.